This is a series of videos that we're using to teach medical students about the physical examination. When you first get into medical school, you have to learn how to take a history from somebody, so how to get the person to tell you their story, and then also how to do a physical exam. We think it's really important for medical students to learn about what's different about doing this in older adults. We call it geriatrics. I hope that you'll enjoy these videos as well. What are 3 conditions that you should screen for when you're seeing an older adult with diabetes? So the 3 things that I think we should screen for when we're seeing an older adult with diabetes are cognitive impairment, frailty, and depression. You thought I was going to say, look at their feet, didn't you? Well, you should do that. It is important to do a good foot exam with the shoes and socks off, and also to look at the person's gait, how they're walking. But the things that you might not think about are the brain aspects of diabetes. Diabetes is a disease of older adults. In the US anyway, 44% of those with diabetes are older. The peak prevalence is in the 75 to 79 age group, with 22% of people in that age group having diabetes. So older age is a risk factor for diabetes. If you're looking after people with diabetes, you're going to see a lot of people in the older adult age group. First, let's talk about how diabetes can affect cognition. Did you know that diabetes, type 1 or type 2, increases the risk of dementia? That's also known as major neurocognitive disorder. And the most common cause is Alzheimer's disease. Diabetes actually increases the risk of Alzheimer's as well as vascular dementia. So you might think that the reason that diabetes would cause dementia is because it would cause strokes, and that's probably a part of it, but it also increases the risk of Alzheimer's, which isn't purely stroke related. You may have heard some people refer to Alzheimer's disease as type 3 diabetes, and that could be because it does seem like glucose metabolism plays a role in the causes of Alzheimer's. The glycation end products that are in excess in someone who has diabetes is toxic. Those compounds are toxic to the brain. Even with insulin resistance and not full-blown diabetes, there seems to be some effect on how amyloid protein, which is in excess in Alzheimer's, is cleared from the brain. Of course, diabetes is a risk factor for cardiovascular and cerebrovascular disease, and we do know that people who have a stroke are more likely to have dementia. We also know that if someone's living with Alzheimer's and they have a stroke on top of that, their dementia symptoms are going to be much worse than if they just had Alzheimer's alone. Having Alzheimer's and stroke-related dementia is a condition we call mixed dementia. You might be wondering if tight glycemic control is useful then in preventing dementia. The answer is we're not sure. The Accord Mind trial, which included some researchers from McMaster University, looked at very tight glucose control in older adults, and they did find that there was a decrease in brain atrophy in subjects who did have tight control. They were followed for about 40 months. However, in that study, there was not really an improvement or a difference in the person's cognitive performance, whether or not they had had tight glucose control. So I think we need more research to really be able to answer that question about how glucose control could affect dementia risk. We do know that hyperglycemia and hypoglycemia can both increase the risk of cognitive impairment. Recurrent severe hypoglycemia does seem to increase the risk of having dementia. Another thing to screen for in older adults who are living with diabetes is depression. People who are living with diabetes have about a 33% higher risk of having a depression. It's important to know about depression because it's a risk factor for the development of dementia when it comes on in later life, and it's a risk factor for frailty as well. We're going to talk about frailty in a minute. So screening for depression could be an important part of the diabetes exam. So now that I hope I've convinced you that it's important to screen for cognitive impairment, depression, and frailty in an older adult with diabetes, how do you do that? Well, there are some tools that shouldn't take very long to use in the doctor's office. Let's talk about cognitive impairment first. The tools that I use include the MoCA, which takes about 5 to 10 minutes to do. It does require some online training if you want to do it in a standardized way. But the MoCA is a tool that has been validated in many different older adult populations. It's pretty easy to administer and to score. Remember, it's a screening tool. So if somebody scores less than 26, it does not mean they have dementia. It just means that their cognitive performance isn't in keeping with what we would expect for normal aging, and we probably want to do more investigation. Other tools can be used for screening for dementia as well. The MMSE can be used, although that tool does have a copyright. You could even use something like the mini cog. The mini cog, though, is easy, and it basically consists of the clock, a 3-word recall, and that's it, really. A screening test that I would maybe recommend is the mini cog, as well as asking the person what year it is. If somebody remembers all 3 objects in a 3-word recall, the chance that it's Alzheimer's is very low. If somebody's clock is impaired, then that does have a pretty high likelihood ratio of about 24 that somebody has dementia. Similarly, if somebody does not know what year it is, the likelihood ratio for that is closer to about 36. So those would be some high-yield tests that could easily be done in the office in a few minutes. Again, those are screening tools. They're not to diagnose a dementia. Screening for depression, there are lots of different tools that we could use. The ones that I use the most often are probably the PHQ, which is Patient Health Questionnaire, or the GDS, or Geriatric Depression Scale. Both of these have shorter versions with either 2 or 15 questions. And depending on the score, the scores at least are described as giving an indication of how severe a person's depression is. But again, they're screening tools. You're not going to make a diagnosis of depression just based on somebody's score on either a PHQ or a GDS. You have to move beyond the initials to really make the diagnosis. They're good screening tools though, and they only take a few minutes to administer. Screening for frailty is a little bit more complex. There are lots of different frailty scales out there. One of the ones that we use a lot is the Clinical Frailty Scale, which was developed by Ken Rockwood. It's kind of based on an accumulation of deficits. There's a list of over 70 things that if a person kind of ticks enough of those boxes, then they're frail. Some frailty screening tools that you could use in the office also include the Short Performance Physical Battery, Fried's Phenotype, and the Frail Scale. An experienced geriatrician probably feels like they know if a person's frail if they see it. If you've watched the video up to this point, we've already talked about things like depression and cognitive impairment. And those 2 things are risk factors for frailty as well. So you can kind of see how all of these things are related. They seem to actually have a sort of reciprocal relationship so that if a person has one, they're more likely to have another. Why is it important to screen for frailty? Well, we're not entirely sure how we can reverse frailty, but it probably means that we're going to pay closer attention to encouraging somebody to adopt healthy lifestyle changes and to make sure that we're not putting the frail person at risk for other complications. We're going to probably pay more attention to their medication list, and it actually might affect how strictly we want to monitor their glucose control. There's some evidence that older adults who are very frail, for example, those living in a nursing home or who would qualify to go to a nursing home if a bed were available, they may actually do better and live longer with a little bit of a higher hemoglobin A1C, so something that's greater than 8. For most people, that's not the target that they want to achieve, but for frail older adults, that may be a better way to go and a more realistic goal and a healthier goal for that individual. So the next time you're doing an exam on an older adult with diabetes, don't forget about screening for the big 3. cognitive impairment, depression, and frailty. And if you want to learn more about geriatrics, go to www.thewrinkle.ca.